Let's share some slides here. Maybe. All right, thanks for having me. This is another great night of two papers for us to discuss and hopefully have some wonderful presentations and great discussion afterwards. The papers we're going to be presenting tonight are age effect in asymptomatic carotid stenosis in the CREST and ACT-1 stenting versus endarterectomy trials, and outcomes of chronic limb-threatening ischemia revascularization in patients with chronic kidney disease in the BEST CLI trial. Our presenters tonight are for the first paper, Atrium Health, the Carolinas program. Dr. Charles Briggs, who's the program director of the fellowship there, will be kicking it off, and his first-year fellow, Dr. Mani Lasasso, will be presenting the CREST ACT-1 paper. And then Dr. Matt Smeds, who's professor of surgery at St. Louis University, as well as editor-in-chief of JVS Cases, Innovations, and Techniques, will be giving us some background information on the BEST CLI paper, and his first-year fellow, Dr. David Eberts, will be presenting that paper. We have several authors from both papers here to join us tonight: Dr. George Howard from the University of Alabama, Thomas Brott from Mayo Clinic Jacksonville, and Dr. Matsumura from University of Colorado to discuss the ACT-1 CREST paper. And then joining us from the BEST CLI paper, first author, Dr. Mahmoud Malas, senior author, Dr. Catherine Tuttle, and then Dr. Matt Menard, of course, representing BEST CLI, will be here to discuss as well. We have two excellent guests leading our discussion tonight after each presentation: Dr. Cosmas Paraskevas from, as we all heard, from Central Clinic of Athens, Greece, and Dr. Akiko Tanaka from the University of Texas, Houston, will be joining us tonight for discussion. Just some reminders: please stay muted during the presentations. Place any of your questions, comments, or discussion points in the chat box, and the moderator may call on you to speak as we go through the discussion. This event is being recorded for on-demand access. And please join us in May. May 14th is our next JVS Journal Club, same time, same place, hosted by University of Maryland and Massachusetts General Hospital. I will also put a plug that the July Journal Club will be another Young Surgeon Section 1, where we focus on research coming from early career surgeon scientists in the JVS. All dates for 2025 are posted at vascular.org, and you can register there for upcoming JVS Journal Clubs. So I'm going to kick it off to Dr. Briggs to start our presentation tonight.
Thank you very much, Libby. Let me just share my screen here. And can everybody see that?
We can see ourselves, Charlie.
Yeah,
oh gosh, I'm sorry.
Click the other three.
Yeah, come on. Try one more time here. Is that any better, or is it the same thing?
They're still looking at my big face.
Oh no.
That's exactly how I feel.
Yeah. Oh, man.
You don't have the excuse that it's 2 a.m. where you are either, so.
No, I don't. I know.
I think you have to close some windows so that there's only like one that you can screen share or something like that.
Yeah. It's on a different tab. I'm so sorry.
Okay, this happens all the time. It's why we practice, and then of course the best laid plans. So
Yeah, of course. I'm sharing my entire screen. I'm just flipping between windows, and it's not sharing the screen that I want to share.
What happens if you minimize out of that window now?
What's that?
What if you minimize out of your URL?
Right,
window?
just minimize the zoom, and then
Not gonna
if
work?
you're sharing your whole screen, it should be there in the background.
Maybe not.
Oh, okay. I swear I've done this.
Maybe you might want to log off and log in back again.
No. All right.
Yeah, that's it. Or just give it oral description and
Yeah, I'm happy to do that. Just a big thank you, first of all, to Misty and Joe for putting this together, and to Libby, to my other presenters, Matt Smads, to the powers that be within the JVS. I really appreciate the opportunity. I won't do too much introduction. I'll let Monty get right into it, but essentially asymptomatic carotid artery stenosis is responsible for, excuse me, the asymptomatic carotid artery stenosis and asymptomatic carotid surgery trials showed that among asymptomatic patients with carotid artery stenosis of greater than 60% diameter of the artery, the risk of stroke or death was lower when immediate carotid endarterectomy was performed than when surgery was deferred. In spite of these data, revascularization for asymptomatic patients is controversial, as current medical therapy, including statins, antiplatelet agents, antihypertensive control, has independently led to a reduction in the incidence of stroke. Most carotid surgeries in the United States are done for asymptomatic individuals, and while there is data demonstrating that age acts as a treatment effect modifier in symptomatic patients, there is not information from randomized trials suggesting that age acts as a treatment effect modifier in asymptomatic individuals. So although recent trials such as SPACE-2 and ECS-2 compared CAS and CEA in asymptomatic patients, they were underpowered for primary endpoints and cannot provide substantive information about a possible age effect. Both SPACE-2 and ECS-2 were multi-center, prospectively designed randomized controlled trials in Europe, intended to recruit over 6,000 patients, but ultimately only recruited less than 1,000. And there was no benefit whatsoever of carotid revascularization over best medical therapy. To address the potential age effect in the asymptomatic population, the study tonight's authors combined data from asymptomatic patients in 2 large randomized clinical trials that compared outcomes of CAS and CEA, those trials being CREST and ACT-1. I'll turn it over to our first-year fellow. He's a fantastic person and a fantastic surgeon. He hails from New Jersey, but attended Cooper Medical School, Rowan University, and then his general surgery residency was at St. Luke's St. Luke's University Hospital in Bethlehem, Pennsylvania. Thanks. Sorry for the confusion and technical difficulties. I'll turn it over to Monty.
Hi, good evening. Thanks to Dr. Briggs for the kind introduction. Happy to be here. Give me just a moment to make sure my screen share goes off without a hitch, and then we should be on our way. How are we looking? Is that visible?
it looks good. Thank you.
Okay, excellent. So as mentioned, I'll be discussing this work on age effect in asymptomatic carotid stenosis as reported in the CREST and ACT-1 trials. The objective here was to assess age as an effect modifier in those 2 prior studies, examining endarterectomy versus stenting for asymptomatic patients. The design of this is a straightforward pooled retrospective analysis of those composite studies. A brief byline about those constituent studies. CREST enrolled a total of 2,502 patients, of which 1,181 were asymptomatic and completed follow-up in 2009. ACT-1 enrolled a total of 1,453 asymptomatic patients, enrolled and randomized in 3-to-1 fashion to stenting or endarterectomy, comprising a total of 1,089 and 364 patients respectively. It's worth noting that the upper age eligibility for enrollment for ACT-1 was set at 79 based on prior data from the published ACST trial, and follow-up was completed in 2013. In terms of methods for this pooled analysis, all of the ACT-1 patients were included, as were 1,091 patients from CREST, corresponding to those asymptomatic patients aged less than 80 and representing a sample size of 548 patients undergoing stenting and 543 undergoing endarterectomy. The primary outcome was defined as any stroke, myocardial infarction, or death within the periprocedural period, as well as ipsilateral stroke within 4 years of randomization. This was a primary outcome in the constituent trials. Secondary analysis was also performed for any stroke or death within that 4-year period. It is worth noting that in terms of the constituent studies, the periprocedural period was defined as 30 days in ACT-1, and for patients that did not undergo operation within 30 days of randomization, it was extended to 36 days in CREST. In terms of methods, age effect was examined using Kaplan-Meier methods and proportional hazards analysis. 4 separate age strata were defined for this work, corresponding to patients aged less than 65, those aged 65 to 69, 70 to 74, and lastly, the eldest cohort, 75 to 79. At the time these strata were selected and defined, there was no pre-existing knowledge of stenting versus endarterectomy treatment differences within those age strata, and age was treated as a continuous variable in assessment of stenting to endarterectomy risk ratio and a spline analysis as well. Just in terms of statistical parameters, data for event rates were assessed at an alpha of 0.05, and significance of interaction terms were assessed at an alpha of 0.1. In terms of results, baseline characteristics between the groups were largely similar. The only significant difference noted was that between stenting and endarterectomy groups, in the eldest stratum, patients randomized to stenting were less likely to be white than those randomized to endarterectomy, and the corresponding incidence percentages and p-values are there, and the visual tabular representation of those data is included here. In looking at treatment differences, for the primary endpoint of stroke, myocardial infarction, and death, there were no significant differences between age strata for the periprocedural period or 4-year outcome. And in looking at the secondary endpoint, stroke and death outcome was significant when testing for age by treatment interaction. Specifically, for patients aged 75 to 79, the risk of stroke or death at 4 years for stenting versus endarterectomy carried a hazard ratio of 4.41. Incidence percentages were 10 and 2% respectively, and p-values were significant. Interestingly, those were not significant in the periprocedural or post-procedural periods, despite being significant overall. In the spline analysis, there was an absent stenting to endarterectomy treatment effect across the age spectrum. However, in the secondary outcomes at older ages, there was a trend toward an interaction, though not statistically significant. Looking briefly, this is the table corresponding to the data for stenting versus endarterectomy treatment differences in age strata. And these are the initial Kaplan-Meier curves. And the spline analysis is here. I would call attention to the figure on the right side of B, just showing it, less smoothness and more deviation toward the extremes of age. In looking at age effect within treatment groups, it gets a little more interesting in that in patients undergoing stenting, there was a significant difference in terms of outcomes with regard to the primary endpoint when looking at the eldest stratum versus patients less than 65. And this was significant both in the periprocedural and post-procedural window. It's worth noting that there were no differences in outcomes that were significant between the other age strata related to those less than 65 years of age. And with regard to the secondary endpoint, the eldest cohort, again, had a significantly increased rate of occurrence in both the periprocedural and post-procedural period as compared to younger patients. These differences, again, did not occur between any of the middle strata and the youngest patients included. Across the board, there were no significant risk differences for either endpoint with regard to patients undergoing carotid endarterectomy. I've highlighted here just the significant rates noted for the peri and post-procedural periods within the table represented in the initial study. And in looking at the discussion and interpretation, it's quite interesting. There are no difference in risk by age detected for the primary outcome, directly comparing stenting to endarterectomy. It's also worth noting that there doesn't seem to be any effect modification with stenting versus endarterectomy efficacy with age as a continuous factor. We did, of course, see this approximate 4-fold risk increase of secondary adverse outcomes in patients in the eldest cohort. And despite the hazard ratio differences, it is worth noting that these event rates were low, absolute differences were relatively small, and confidence intervals were somewhat wide. Fewer patients were analyzed for endarterectomy, so with lower event incidence and statistical power, we have to be cautious about conclusions drawn. There are some fairly generic and standard inherent limitations of the study design simply because of its retrospective nature as a pooled analysis and looking at possible unforeseen biases. Looking at the data set, it is worth noting as well that these data do not account entirely for some of the procedural advancements and patient selection advancements occurring since TCAR has largely supplanted transfemoral carotid stenting, of which many patients in this cohort initially would have been randomized to. It's also unclear exactly what implicit drivers of age-related risk are. Obviously, age alone is an insufficient surrogate for other factors, including anatomic and comorbidity complexity of patients that may be rooted out with more careful patient selection. As Dr. Briggs had mentioned, obviously ECST2 and space data have not given us, definitive answers on these therapies alone versus best medical management. And I know we are looking to CREST-2 as well for some ongoing information on that front. It's worth noting that when analyzed separately and taken in their original form, there were no significant result differences for advancing age in either the ACT1 or the CREST trials. It remains important to scrutinize older patients for individual factors that portend added risk, especially when looking at them as candidates for carotid stenting, and obviously more work will need to be done on this front moving forward. In conclusion, and to summarize, asymptomatic patients analyzed and treated between the years 2000 and 2013, there were significant stenting versus endarterectomy differences in stroke risk by age for the secondary stroke and death outcome. Higher risk among those in the eldest stenting cohort as well. No age-related treatment differences were observed with respect to the primary outcome of stroke, MI, or death overall, though trends toward increased risk in the eldest cohort definitely were noted among patients offered stenting and analyzed for undergoing stenting. At this point, I would again just like to thank everyone for allowing me to participate tonight and to be here, and to open the floor to further discussion.
Thank you for that excellent presentation. Dr. Perez-Cavas is going to lead the discussion tonight.
Right, thank you. It's a real privilege to be here. And great talk, really. Very nice talk, very nice presentation. Well done. So, did you, by any chance, analyze stroke alone? I mean, not the composite endpoint, but just stroke alone? Because, stenting and endarterectomy are not designed to prevent MIs. They're designed to prevent strokes. Did you have any subgroup analyses or anything?
You can go ahead, Dr. Howard.
I will say, number one, I'm an old man and my memory is failing. I believe there was only one periprocedural death, and it was in the CREST study. John, please correct me if you had one. And so basically, the stroke plus death analysis is largely the stroke analysis.
Okay.
I would just add that most of the deaths are in fact due to a stroke. And so that's why George said there's not really much difference between a stroke and stroke death. I think the question you're asking, Cosmos, is a very important one for all of vascular intervention. If you look at rupture risk of aneurysms using Kaplan-Meier estimates for rupture only, I was taught that a 6-centimeter aneurysm has about a 5 to 10% risk of rupture each year. But there's a recent paper in the journal that Ron, I think, or the editors picked for editor's choice from Kaiser Permanente, showing if you use restricted mean survival, the rupture risk at 3 years in the Kaiser system for a 6-centimeter aneurysm is 6%. That's 2% a year. Obviously selected patients who are not operated on. But I think it's a very important question. Should our primary endpoint be stroke prevention, or it should be the prevention of stroke and death? Because I think patients want to avoid both. But that's a good question to ask.
Well, I mean, I think during the, if I may add, I think deaths during the periprocedural period, I think this paper, again, please correct me if I'm wrong, has a 120-day periprocedural period. But if you're dying in 120 days of a procedure, procedure might have something to do with it.
George, I just want to clarify that was the original CREST periprocedural. And in our analysis or our planning meeting at the O'Hare Hilton before we ever looked at the data, we shrunk that interval to 36 days because you recorded post-randomization stroke. We recorded in Act 1 post-procedural. And so that made the 30-day post-procedural equivalent to 36 post-randomization because the average time to procedure was 6 days.
And for the young faculty on the call, I think what John is speaking of you should listen carefully about the challenges of merging two studies that sound so incredibly similar. But once you open the hood, it turns out that one of them has an electric motor and one of them has a gas motor, and they're really quite dissimilar in a lot of different ways.
Cosmos, if you don't mind, I'd just expand on that.
Yeah, please do.
Tom Brott and the late Bob Hobson and Kenny and I met sometime in the early 2000s, just about the time when CREST expanded asymptomatic patients in enrollment. And we had tried to come to agreement on resolution of endpoints so that we could do a pooled analysis. And a pooled analysis is really important when you want to do subgroup assessments such as age effect or sex effect. We power our trials to the primary endpoint always using all patients. So if you want to look at subgroups, you need to pool with somebody. And we could not come to agreement at that time because we had already started our trials and enrolled. And you cannot change things midpoint. Particularly interesting would have been if we could have resolved minor and major stroke. So we could look at stroke severity, but we had different methodologies. We both had independent stroke adjudication committees, some of which exercise quite a bit of freedom. For example, blindness in an NIH stroke scale is not a 6-point jump, but they felt that's a major stroke, which I agree with. So we could not resolve those. I would encourage everybody who's going to do these trials to try to seek out your competitors around the globe and try to work ahead of time to resolve these definitions so you can do a better pooled analysis.
Okay, great. Yeah. So we have some questions from the floor. There's a question from Dr. Babak Abai. Why do you think the older group do worse with stenting? Could this be different for TCAR patients? Who would like to answer this question?
Well, this is Tom Brott. In the literature, in fact, a comment was made by the presenter that age is not a good surrogate, that we need better surrogates, and I think we go along with that. But today, 2025, age is the best surrogate. So when we talk about calcification, we talk about tortuosity, there's no data. Okay, at least we have data on age. And I was presented some of these results at a meeting, and a very prominent neuroradiologist, interventional neuroradiologist, he talked about procedures within the brain, AVMs and aneurysms. And when he knew that something kind of didn't go quite right during that procedure, his first concern was how old was the patient, because he found that he could get away with all kinds of things in somebody 50, but in somebody 75 and 80, the very same little problem that he had, he'd end up with a lesion on the MRI scan. And his point was he was not so convinced with tortuosity and with calcification. He was more interested in our ability down the road, not this year, but maybe in 5 years, to measure collateral circulation in the brain. And I think we've all noticed that patients who have a bunch of lesions by MRI scan, chronic lesions, totally silent lesions, those patients, that may be an additional surrogate that we've got to look into until we can really measure. But when we can measure collaterals, I think that will be a real advance in terms of selecting patients.
Okay, I see Dr. Machimura and Dr. Howard have raised their hands.
John, why don't you go before me, sir?
I was going to make 2 quick comments. We want to leave time for Bess, but one thing is, if you pull up figure 2B, the Kaplan-Meier, there's not only an elevated late stroke rate in the elderly patients with stenting. It's only 6 events, but you can see that it's late events. That concerns me. And I think that caused me to worry about things like fracture and restenosis. As you know, in our circulation paper, fracture occurred in a single-digit % of exact stents, but was not associated with stroke, the primary endpoint, death, or reintervention. But I also want to emphasize something the presenter said, but we knew in 2004 when we started ACT, which was after CREST was started, that patients over 75 did not benefit from endarterectomy. While there's a higher risk of stroke with stenting, clearly in this data, that's evident, death stroke, I guess I should say. We also know that intervention is generally not indicated on an unselected basis for people who are asymptomatic and 75 or over. And Cosmos in Europe, you probably think it's independent, but I just want to point that out for the US investigators. Tom?
Your database, John, seems to indicate that most of your colleagues disagree.
Yes, I am constantly showing that slide. I could share it, but when Allison published her paper in 2004, those Kaplan-Meiers are only the young patients, less than 75. And in fact, 74% of the men and 60% of the women die within 10 years in her 10-year follow-up in 2010. These patients, it's very hard to tell a patient, we're not going to treat your severe stenosis because you're going to die. That's a very difficult conversation. You have to say it differently, obviously. But I will tell you, many patients do recognize they're at the end of life and don't want additional surgery. Of course, cognitive improvement would change this completely if it was ever proven to be true.
One other point I'd like to make, and time really flies. The first patient enrolled in CREST was 26 years ago, and the last patient enrolled in CREST was 17 years ago. The last patient enrolled in Act 1 was 12 years ago, and most of the patients enrolled in both trials were in the early part of the 2000s. So thank goodness technology improves, training improves. We'll learn more about TCAR as things go along, and we'll be unblinding the CREST-2 trial August 1st, and we'll have the results the first week in August, and hope to be publishing sometime in the fall.
That would be great. Dr. Howard?
I'm sorry, I'm a geeky statistician, and so I feel like sometimes I cannot help but tell the story of when Tom and I and a wonderful group of collaborators were planning the study. We were considering excluding people over 80 years old into CREST and also CREST-2, I might add. And the reason for that was that we thought that the non-invasive stent would have such a benefit of a carotid endarterectomy that stent would just kill the older people. Not kill, that's a bad analogy.
Yeah.
Would have such a great benefit in the older people. And I will tell you, the great joy of doing science is being wrong. And boy, we were wrong. I will tell you, when I was doing the analysis of this way back when, and stent turned out worse, what you do as a statistician is go back and make sure you have your 1 and 0 coding correct, so that you're not getting it backwards and getting ready to say the wrong thing. I have been in this business since 1986, and the single biggest surprise in my entire life, professional life, was that there's apparently a higher risk in the stenting group, in the old people. Never thought it would happen. Never thought it would happen. In fact, we almost didn't include those people because we were sure it wasn't going to happen.
Right.
My second point is, let me encourage you to separate these findings into peri versus post-procedural. During the wonderful presentation, it was pointed out that neither the peri nor the post were significant, but collectively they were significant in the older people. And of course, that's because of sample size. And what the great challenge of working with you gentlemen and ladies is that you're too good. There are not enough events for the statisticians. And so what we
That's
have
true.
to do is to have more events. And so this is from memory. In the peri-procedural period, in the oldest group in this paper we're discussing, it was 11 versus 2. And in the post-procedural period, it was 9 versus 1.
Okay.
Okay.
Understand.
And so this is not just a peri-procedural phenomena, but also a post-procedural phenomena, although we don't know significantly if either one of them are significant. It is a great, if people would like to talk about the geeky statistics of this, please feel invited to call me and I can go through more of this.
Great.
This
Thank you
has
so
been
much for that.
excellent discussion, and I really appreciate all of the expertise here tonight. This has been really wonderful. I do want to give the second paper some time for equally
We
excellent
have
discussion. So I'm gonna pass
three
it on.
questions. We have
Sorry?
3 questions. Dr. Malas is asking that this paper is different from the original paper we worked on symptomatic and asymptomatic pain in CREST. Any ideas on why the difference? Question by Dr. Malas.
Well,
Can we
the
answer that,
difference
please?
is the number of patients. We only had 1,181 patients that were asymptomatic in CREST, and you split that in half. And even with the combined numbers, over 4 years, there were only 22 strokes in the CAS group. So again, you get back to Geeky George. He's always looking for more strokes.
I was going to say it's not the number of patients, but the number of events.
Right.
And I will say that in an area, also in an area, symptomatic status makes no difference at all on a relative basis. I've never seen a field where symptomatic versus asymptomatic is less important than in carotid revascularization. Basically, it's a, two times effect.
That's relative, not absolute. Just keep that in mind, everybody.
Relative. I did
Let me
Relative.
help you. My
As
colleagues.
physicians, we deal more often in absolute risk reduction.
Okay. Thanks,
We have to
everyone.
give the best group some time.
So Mr. Humphries says we should go ahead and move on and move on to the second paper, right? And so Libby, yeah, if you could please continue with the second paper.
Yeah,
Thank you all for your feedback.
Thank you so much for leading that discussion. Thank you for that excellent discussion. I'm sure the authors would be happy to answer questions in the chat box too if there are other questions that come up. I'm going to pass it over to Dr. Smeds to introduce our next paper.
Thanks.
All right, I'll start with the most COVID era thing ever. Can you see my screen?
Perfect.
Yes.
Well, hello. Thanks to the Journal of Vascular Surgery for inviting St. Louis University to be involved with the JVS Journal Club tonight. I'm Matt Smeds. I'm a vascular surgeon here at SLU. I'll be introducing the paper, and our fellow will be presenting the paper entitled Outcomes of Chronic Limb-Threatening Ischemia Revascularization in Patients with Chronic Kidney Disease in the BEST CLI trial by Mahmoud Malas and colleague. I don't have any relevant disclosures. Chronic kidney disease is one of the most common medical comorbidities in patients with chronic limb-threatening ischemia. It affects nearly 25% of these patients. In patients with concurrent chronic kidney disease or end-stage renal disease, NCLTI, revascularization is associated with increased rates of subsequent amputation, reintervention, and mortality. These patients are more likely to present with ulceration, gangrene, and heavy calcifications, and are more than 2 times likely to have post-op infections, sepsis, MI, and stroke. The optimal treatment strategies in these complex patients is unclear. Other studies have shown increased rates of reinterventions in patients with CKD who are treated with endovascular therapy, but lower rates of amputation and mortality while performing bypass in this patient group may lead to increased rates of amputation. The BEST endovascular versus BEST surgical therapy in patients with critical limb ischemia trial was a prospective multicenter randomized open label comparison trial to evaluate the effectiveness of BEST surgical to BEST endovascular therapy in patients with CLI. It was the largest randomized controlled trial to date investigating chronic limb-threatening ischemia, and the primary outcome suggested that in patients with adequate greater saphenous vein for surgical revascularization, surgical revascularization resulted in reduced major adverse limb events and death when compared to the endovascular group. In patients who lacked the adequate saphenous vein conduit, the outcomes in the two groups were similar. Outcomes related to patients dependent upon their kidney disease were not reported. That brings us to the paper to be discussed, and I'll turn over the presentation to my friend and our first-year vascular surgery fellow, David Eberts.
Excellent. Thank you, friend, Dr. Smeds. So the goal of this paper ultimately was to investigate the impact of CKD on the outcomes of infrainguinal revascularization, utilizing the data that we now have from the BEST CLI project. The BEST CLI, we've already discussed what it is, and we all know it. The authors here utilized patients within this data set and separated them into 3 groups based on their CKD stage. Group A, which is the no disease to mild, is CKD 1 to 2 or no CKD at all. Group B, the mild to moderate, stage 3 to 4, and Group C being the end stage dialysis dependent or CKD 5 patients. The primary outcome for this paper was composite outcome, combining both male and all-cause mortality. Meanwhile, they had several secondary outcomes looking at male and mortality individually, looking at amputation-free survival, major reintervention, any reintervention, as well as any major cardiac event, MACE. The analysis included for the categorical and continuous variables chi-square test, but the main crux of their analysis utilized the univariate and multivariate Cox regression analysis. The variables they included in these regression analysis, in addition to the CKD grouping, was age, sex, race, ethnicity, antiplatelet use, and other comorbidities that were either significant in their initial chi-square test or other ones that were relevant and known to the disease process. In addition, their other main analysis utilized the cubic splines method, which I don't know how many people are familiar with it, but it was able to examine the effect of GFR specifically on their composite primary outcome of male and death. And shortly, just cubic splines are a way to look at continuous variables that have varying effects that do not fit a linear curve for usual logistic regression. Basically uses a cubic polynomial curve to understand these nonlinear relations. So we'll look at that here in a little bit. Their results from the demographics, they were able to include a significant more amount of patients from BEST CLI. 1,700 of them included kidney status. The largest group was Group A, which was the no disease to mild CKD, had 73%, and they had about 14 and 11% within the Group B and C. The main differences between these groups show that all groups were more likely to be male. In Group A and B, interestingly enough, they were more likely to be older and had a higher prevalence of smoking. In the more advanced CKD grouping, they were more likely to be Black or Hispanic. Interestingly, we're more likely to be younger without smoking, but had increased hypertension, diabetes, CHF, COPD, as well as strokes and TIA, fitting along with their overall comorbidity of being an advanced CKD. For their perioperative data, medications were roughly the same between all groups. Statin was used more in the moderate group. Otherwise, the antiplatelet regimen was unchanged. For the actual operations for an open bypass that the patients underwent, they were more likely to be a femoral tibial or pedal bypass in all groups. For endovascular, in the advanced Group C, they were more likely to be tibial and pedal interventions. And then the use of atherectomy in particular was most likely seen, or was more seen in the Group C advanced as opposed to the healthier population. Their main primary outcome, this composite of male and death, as seen here in the Kaplan-Meier analysis, was a stratified drop in survival based upon the grouping, with the Group C having over 70% male mortality by 3 years. And the main factor, which we already know, but now have a lot more solid data from this group, worse male and death with worse CKD status. Looking at their multivariable regression, first at their main primary outcome, there's an increased risk in Group B as well as C, with hazard ratio up to 2 for Group C. And for their secondary outcomes, looking at mortality separately, Group B was 50% higher, and Group C was 3 times as high in terms of their mortality at 1 year compared to Group A. Looking at cardiac events, Group B was 40% higher risk compared to the baseline group A, and then group C had triple the risk. The spline model, which is one of their main novel approaches that is hoping to look at the actual relationship between GFR and the risk of mail and death, showed that at an eGFR of 30, right here, where the curve actually crosses midline, is the cutoff when the risk high to the left and low to the right differentiates for these patients, meaning the risk increases as soon as the eGFR drops below 30. But interestingly enough, between the open and the endo group, the open being the solid, endo being the dotted, is below 30. There was no difference in the actual hazard ratio below that threshold. When eGFR greater than 9, going back to healthy, normal patients for the most part, it shows what we already have known about in the best CLI before, which is when there is an open bypass option with a single segment greater saphenous vein, it is more favorable than an endovascular approach. When looking specifically at long-term outcomes in the dialysis-dependent patients only, the main significant finding in this analysis was that endovascular was associated with a 41% lower risk of all-cause mortality, but did have double the risk of reintervention. Their long-term Kaplan-Meier results, which I think shed some really interesting light in terms of their actual long-term outcomes, is that overall these patients have greater than 50% mortality in 3 years. And at that, for those that survived 3 years, that single saphenous bypass compared to open, or compared to an endo, remains actually a higher mortality. But on the converse side of that, those that survived out 3 years on dialysis had better limb salvage and lower mail. Overall, the limitations of this is this obviously was not a randomized study that was randomized and stratified based on kidney function. So it was extrapolated from the main best CLI stratification. And it might be underpowered due to the low sample size of the advanced kidney function. As a reminder, that group B and C only had 14 or 11% of patients in that population. As well as there were other co-founders that the authors couldn't necessarily account for given the data that they had, such as calcification, how long they were on dialysis, and other important medications. But overall, patients with CLTI and CKD had poor outcomes in terms of limb loss, mail, death, and MACE. eGFR 30 appears to be that sharp difference in terms of when that risk really becomes significant, regardless of open or endovascular revascularization. And that in dialysis patients, long-term endovascular was associated with the lower mortality, but increased rates of reintervention. And lastly, the authors do note that this spline model is a novel approach that can be used in other studies, that eGFR can be used as opposed to arbitrary eGFR cutoffs, but looking at an eGFR of 30 is maybe when it really does become clinically significant. Thank you for letting me present, and happy to hear the discussion.
Excellent presentation, Dr. Eberts. I'm going to hand it over to Dr. Tanaka to lead the discussion.
Hi, David, great presentation. So in this paper, was there any discussion about the success rate for the endovascular? Because the initial this age happened to have enrolled with a patient who can do both the endo and the surgery too. So what was the rate of the success rate in the was there any data reported in this paper? What was the success rate for endotherapy in the accordingly to the group A, B, and C?
Might have to ask the authors, because I don't remember, and looking at it again, I don't think there was the actual success rate recorded within this data, unless I'm wrong.
Okay, maybe that's a question for the reader. So after seeing this paper, I don't see any question coming out through yet. Do you think there was a after reading this paper, would you change your practice with the GFR of 30 or not?
I think it would, in terms of that we look at patients who have a lower GFR and those that are sicker might need a more aggressive approach to actually have, a inline outflow procedure to actually get that healing of wounds, since the majority of them do present with ulcerations. And so I think for this paper, I might think to more favor towards an actual bypass in terms of durability. But given this, below 30, an endovascular approach, if feasible, is equally as likely. So I think, similar to how people look at best CLI versus basal 2, really you fit it to the patient, as long as they're open to both. An endovascular is just as safe and durable in terms of this paper.
Okay, I don't see any question in the chat. So if any one of the author can answer the question, was there any difference between the according to the group A and B and C? Was there any difference between the success rate for the endovascular therapy? Because we all know that CKD has more calcified lesions, sometimes higher failure rate. Was it analyzed in the study?
Yeah, hey, thanks, Tamaka. Sorry, I just literally an hour ago fell and wiped out and dislocated my thumb, so I was like ready to turn my screen on. But first I want to say thank you for picking up our paper for the journal and journal club, Dr. Weaver and Misty, and then also David, I think, did a great job presenting. Phenomenal, really, job. The data that you were asking was not specifically reported, but I think the key point first was that, in this group of patients, when there is significant end-stage renal disease, and the dialysis specifically, the rate of amputation-free survival was so low in general, which is not a surprise. I think majority of vascular surgeons know that they do, so poorly. And there's significant limb loss and mortality in this group of patients. So it was really sobering to see how high is the mortality rate, even up to 2 years, and limb loss in general, just overall. And we have shown this in multiple other papers in the past, looking at national data, including USRDS data, which include all dialysis patients in the country. So that was really the main thing that I took out. I mean, specifically to answer your questions, we did not look at, success rate percentage-wise, but we can go back and look at that if you like. But in general, like what we did, what David was bringing up, the main difference was that we looked using a spline model, because it is really in the past was the cutoff arbitrary and used based on cutoff of GFR, and we follow usually the National Kidney Foundation cutoff for these, but surprisingly, when we used the spline model, the cutoff came up to be 30, which is what the National Kidney Foundation always said all along in all the literature. And I also want to thank my co-authors, and specifically Dr. Tuttle, who's here on the Zoom, and hopefully she can comment as well. She's a phenomenal nephrologist who have done amazing research and helped tremendously with this paper. And also Mo, who is one of my postdoc, who helped a lot with this paper. But the key finding was that we kind of proved, using really an independent statistical method, that at age of 30, a GFR of 30 is when you can start seeing a difference. When you went below 30, there was no difference between the procedure. But if they gotten over GFR of 30, then the main finding of the best CLI remained, which is that bypass is better. And then finally, if you looked at male for GFR, less than 30 was higher, essentially. So when we looked at dialysis patient specifically, like David mentioned, mentioned that the endovascular procedures did better, which is opposite to what best CLI found. However, again, I caution, this was a small number of patients on dialysis. And they had essentially more re-intervention with the endovascular, but better amputation-free survival.
Okay. Thank you.
Dr.
So
Tuttle,
Dr.
did you have something to say? Sorry to cut you off, Dr. Chimaka.
no, it's okay. Go ahead.
No, this is Kathy Tuttle. I was just gonna add, thanks for including me. Yes, I am a nephrologist, so I don't normally spend a lot of time talking about these issues with vascular surgeons, so I appreciate the opportunity. And I think what Dr. Malice and Dr. Ebert said is really important, is if you actually look at the stratification, if you will, of risk by eGFR, it is nonlinear, but it aligns very well with our CKD classification system, because CKD less than 30, which is the cutoff for CKD4, was exactly the inflection point where we really saw risk go up. And then at the other extreme, as you pointed out, David, is at 90, that's where you really saw that you could detect a difference between the two interventions on this outcome, right? And then in between, 30 and 90, those confidence intervals largely overlap. So even with mild CKD, you see an attenuation of benefit, of the intervention that was tested. So, that's an important nuance. And I think it shows, if you will, the continuous nature of risk. And as kidney function declines, it gets harder and harder to show a benefit of these interventions on outcomes. And again, I come from, an internal medicine heritage into a medical subspecialty. I guess the other thing that was very interesting to me, though, in the eGFR group less than 30, the only thing that was associated with a difference in outcome was use of antiplatelet agents. So if a person was not an antiplatelet agent user and their GFR was less than 30, they had a much higher risk of adverse limb events. So I realize this is a surgical audience, but I think the message there is that the one thing that may actually help those patients is to give them antiplatelet agents. And, we do have a problem called renalism, which is people with chronic kidney disease, especially advanced stages, are less likely to get effective therapies. And we see this for other therapies like SGLT2 inhibitors, even ACEs and ARBs, as people are less likely to give effective medical therapies, yet they're the people with the highest absolute risk who benefit the most. So again, I know you're surgeons, but I think the one thing that, and again, it is post hoc, and so we have to consider exploratory, but the one signal were to benefit was actually use of antiplatelet agents when GFR was less than 30 for the male outcome. So just some other observations from a different perspective.
I like that renalism. We'll coach on that, Dr. Tuttle. Thank you.
Well, I think it's a message to all of us, is highest risk patients, at least for I guess for medical therapies. I guess we can't say that for surgical therapies, but they didn't do worse than, I mean, there was no difference between the interventions. But, we tend to give medical therapies less commonly to people with advanced CKD, but they across the board appear to benefit the most. Even with the same relative risk reductions, you see the absolute risk is so high, there's more absolute benefit on the outcome. And that's whether we're talking about male or mortality or cardiovascular events or kidney failure. And thanks to all of you for the labor of love to keep those vascular accesses going too when they do reach kidney failure.
Well, thank you, Dr. Tuttle. So it was also interesting that the cohorts, the group C, the CKD4 and 5 had the youngest population in your study. I think that's also a great findings of this study. So there's a question from Dr. Matsumura about the was there a male only analysis? So just looking at the major adverse limb event, excluding a death, was it were the analysis for survival performed without excluding the death, just not the composite, but the male only? I think this is a question for the authors.
Yes, that's in the supplement. That's what I was looking at when I was looking at the Cox model for that.
Yeah, I don't know if they're on, but yeah, they have several really good, because they went through all the secondary outcomes on their own separate univariate analysis as well. And I didn't include it because it does show the same trend with male alone, that you have that stratification really began in that group C. And I think if I recall, it was over 60% at 3 years alone, just with male.
So there's also a question for, was there no option revascularization? I think this could not be included in the trial. There's a question about is there option for no option for vascularization? Was it data on this? I would assume the patient only indicated for the treatment was analyzed in the study, so I don't think this was analyzed. Is it correct, Dr. Molas?
Yeah, that is correct. This is a randomized trial, so they either got this one option or the other. And then for the earlier question, also for Dr. Matsumoto, so that there was 50% essentially male with GFR less than 30. Meaning higher, higher male when you look at GFR less than 30. And that was driven by both, the death and also the amputation.
Yeah, so I saw that and I agree that that's a profound difference. My question was that by Kaplan-Meier estimate or was that a restricted mean survival analysis where deaths had that impact? In other words,
Both.
are the
Yeah.
patients dying no matter what? And the few that live end those better.
Yeah, no, it's a very, I know exactly what you're thinking, and this was not really Kaplan-Meier analysis, but more, but again, if you look at all the entire cohort with like GFR less than 30, and specifically the dialysis, and you look and see what's their amputation survival, amputation-free survival, it's really make you think like, why are we operating on these patients? That's like the biggest thing. And, we looked at USRDS data, in which had, at that time when I did this analysis, had 500,000 patients on dialysis. Almost 70% of them were dead by 5 years or lost their limb. And even when you look up to 2 years or 3 years, there was more than half the cohort was gone or lost their limb. So, and we all deal with this, right? We do everything we can for these patients, and then the hardest thing I always think for a vascular surgeon was when they do an amputation and they have to ligate the bypass that is working. It's patent, but still the limb is not surviving. And you see that mainly in dialysis patients. So, still, I think it's a unique finding. I think at least it can deviate and raise a lot of numbers, but it makes sense. I think these patients have different skin, the way they heal. I think yes, better, although that they need more intervention. So that I think another interesting thing. And then finally, like really verifying that the GFR of 30 cutoff that came from all our nephrology colleagues makes a lot of sense clinically. And it's a true inflection point, and it correlate really with what happened, where the difference start become like very statistically significant, compared like less than 30 compared to normal. Again, I'm sorry. I'm sorry I couldn't turn my camera on. You don't want to see me right now because I'm in pain.
Well, I want to thank everybody for being here, and I want to thank the Young Surgeon section, Dr. Libby Weaver, for hosting, our phenomenal moderators all the way from Greece at 2 a.m, which you got to give you credit. I love it. It's always nice, and thank you to Dr. Tanaka for being here as well. And then the authors. Having Dr. Tuttle, Dr. Matsumura, Dr. Malas, even though his finger is dislocated, and all of them, the authors be here is really helpful. And then finally, of course, to St. Louis University and to Carolinas University as well for presenting. We'll see you all in May. Have a great night.
Thank you.